אנחנו רוצים להיות בזמן, אז אנחנו מציגים את האורחת שלנו מחול גם בפני אולם מתמלא. אני מבקש שהנכנסים בשקט. I will present Dr. Stuber in English. Dr. Margaret Stuber is a child psychiatrist. אפשר בשקט? She is a professor of psychiatry at UCLA, which is totally different from what is written at the program. And she is a chair of medical education at UCLA presently. She is really the pioneer in the area of PTSD and serious pediatric illnesses in children with medical conditions, including cancer and liver transplant. She has edited the Bible, the textbook of pediatric psycho-oncology. And during the past 15 years, she's serving as a pediatric trauma and educational expert for the National U.S. Child Traumatic Stress Network, developing training programs for clinicians working with traumatized children and families, and I think you're going to tell us about that. So it is my great pleasure and honor to welcome Dr. Stuber.
I am very grateful to be here. This has been a splendid program so far, and I feel honored to be a part of it. Even though I think my vocabulary in Hebrew now is up to 3 words, I was at least able to understand most of what was presented, and I'm hoping that I'll be able to build on it. I don't have a lot of slides because I really wanted to be able to build on what I understood of the audience once I was here. And so I'm also going to be very interested in what kinds of questions you are wanting to ask. The title is Alleviating Post-Traumatic Stress in Medical Settings, How to Do It and How to Train for It. This was given to me as the title, and I'm going to try to represent it appropriately. Let's see, so am I supposed to do, is this going to do anything? Ah, it's not clicking. No. But that's, let's see.
The down arrow.
The down arrow, okay.
Yes, from the right to left arrow.
I tried right and left and down. If necessary, I'll do it without them at all. Oh, I can just, a keyboard, how novel, thank you. Okay, all right. What you noticed with Dr. Shemesh and me is that we have been trained to have our second slide always be the disclosure slide. And so that is a rule in the United States, so that's why both of us have done it in this way. But it allows me to also talk about what I am doing at present and sort of the context in which I work. As was mentioned, I've been involved with the National Child Traumatic Stress Network, actually since it started in 2001. And so I was able to be involved with Ann Kazak and with Nancy Kasem-Adams right from the beginning in developing the medical traumatic stress materials that are available on the National Child Traumatic Stress Network. I don't know how many of you are aware of those materials that are there, but there are handouts that can be given to parents. There are handouts for children of different ages. I haven't looked at them recently. They were created in about 2004, but I don't think they're too out of date since they're not about anything medical. They're really about the kinds of issues that happen with kids and their families. But as was mentioned, what I've been doing in recent years with the National Child Traumatic Stress Network is educating clinicians around the United States in how to improve their work with traumatized children. So it's not unique to medically traumatized kids, it's with children who are traumatized in all kinds of different ways. The National Child Traumatic Stress Network, I think, is now up to 86 sites across the United States. It's relatively evenly divided between sites that are primarily clinical sites, mostly community-based sites, and university-based sites that are more educational. And the idea of the way this was created was that we had university sites that would create and test interventions, and then they would be utilized almost immediately at these community-based sites. With the educational program that I work with, we do training in both kinds of contexts, which is actually very exhilarating, although challenging, because we are training people who are in training programs to become social workers, to become psychologists, to become psychiatrists, as well as training people who are already immersed in clinical work with traumatized children and families. Most of these are working with trauma that would be more generally, general types of childhood trauma, child abuse, sexual abuse, but we do have some that are in medically traumatized situations. This was something that was a very unpopular stance when I first started, but now Dr. Shemesh is so much more outrageous than I am. It is easy for me to talk about some of these things. The kind of traumatic stress that you're dealing with is more of what we would now call chronic traumatic stress rather than just PTSD. And there are lots of implications of that. Chronic traumatic stress disorder is not an actual diagnosis. It is something that most of us in the trauma field have talked about for a long time, but as Dr. Shemesh would tell me, it has no data. So we would not be able to actually, so it's never actually made it into any of the diagnostic manuals. And perhaps that's appropriate. What's important about it is what we've been saying, that one-time traumatic events, being hit by a car, being in an earthquake, are very, very different from something like being hit by a car and having a high spinal cord injury, for example. And it's more what Dr. Shemesh was referring to as the things that change the world as you know it, as opposed to changing just the way you're experiencing the world, and you can regain and go back into the world and try to help yourself to change some of your perspective, to be able to re-equilibrate what is actually dangerous. So some of the children that you're going to be working with are children that whose world has really changed, and for some of them it will be able to go back to normal. When I first started working in pediatric oncology, I was working with bone marrow transplants. At that time, our survival rate from bone marrow transplants was roughly 50%. And so the parents and children who left the hospital and were survivors were told, take care of yourself and try to pretend this never happened. Go on and live your lives. Well, I mean, now you all laugh. That's obviously ridiculous. What it did, though, was create a wonderful setting for me to study PTSD, because the children and the parents completely did not talk to each other about their symptoms. And so when I went to meet with the children and the families, the parents would be sitting in their kitchens sobbing and telling me, thank goodness my child has no symptoms, they are fine, we never talk about it, and they are fine. And I go and meet with the children, and they are doing what we would now call traumatic play. They are delighting in giving me pretend injections that will make me die. They're putting together a hospital setting in which monsters climb in the windows and shoot everybody. This is not subtle. But because they had been given this message that they should try to pretend it had never happened, in very well-meaning way, that this made it impossible for either of them to be able to actually process anything that happened. And the same kind of thing was happening when I would talk with people who were long-term survivors. I would ask someone who was now 15, who had been treated for cancer when they were 3 to 6. And I'd say, well, so what do you understand about what happened and what do you remember? Their parents had told me this was ridiculous for me to even meet with them because they had no memories whatsoever. And the child would say, the teenager would say, oh, I remember having a toy dog, and I remember dropping it out of my bed, and they would have to swoop in and take it and sterilize it and bring it back to me. And we would do this over and over again. And I'd say, well, so what do you understand about what was happening to you at the time? They said, well, I know I have this army inside my body that fights off infections, and I had to stay in the hospital because my army wasn't working. And then they would look at me and say, well, that's ridiculous, isn't it? So, well, that's how we explained it to 3-year-olds. And you've never thought about it since then, or you've never talked about it since then, so you haven't readjusted it into a post-11-year-old cognitive framework. Fortunately, we've come a long ways from that, but still having trauma-informed care is not the norm. I suspect most of you have much more trauma-informed care, certainly than we did at that time, but I want to talk with you a bit more about how do you do that and what kinds of resources do we have to do that. So I'm going to talk very briefly about how do we identify those at risk of post-traumatic stress. You've already talked about some of those kinds of issues, but I think that I just want to make a couple points building on some of the things that have been said already. And what I really want to focus on are prevention and reduction of symptoms. I'm not going to be talking about treatment of post-traumatic stress, either the symptoms or of the disorder. That's a lot more than 45 minutes. And it takes a lot of training. The kinds of things I'm going to be talking about are the basic concepts that you need to embrace before you can even learn some of those kinds of techniques. The curriculum that I'm involved with was created to complement the evidence-based treatments that are being taught to clinicians to work with post-traumatic stress disorder in all areas with children. Most of those are very, very structured. They're manualized kinds of treatments, and they are evidence-based. They have been shown to be effective when used appropriately. It varies about what the appropriateness is and the reliability, but we won't even go into that. what we were distressed about, some of us that were clinicians, were that some of the people were being trained to use these kinds of interventions who really had never worked with traumatized children and didn't have the kind of background feel or background understanding that we thought they needed. So we spent about 10 years arguing across the United States about what were the essential items, what were the core concepts that everyone needed to have to be able to work with traumatized children. And so I'm going to talk with you some about that. And that really goes to also about how do we have our staff be trauma informed. So I said just very briefly about who is at risk. I think what you've gathered is that everyone that you are working with in children's hospitals is at risk. And that it isn't just about their assessment of the event, but it certainly isn't that their response is going to be completely proportional to what we think is how bad the stressor is. And what you saw just, I think, in the last talk was the difference between the way that the children rated what was traumatic and what the parents rated as traumatic. This is also true when you bring in what the doctors think is traumatic. It actually has, with the study that we did, there was no significant correlation between what the children saw as traumatic and what the doctors saw as traumatic. There was a mild correlation between what the doctors saw as traumatic and what the parents saw as traumatic, largely because the parents sort of listened to the doctors, but also because they're processing it in a different way than the children are. And some of us talked yesterday that really what you're seeing with the children is that they're reacting to their own physical experience, and the parents and the doctors are reacting much more to the prognosis. What could happen, what is going to happen, what are the probable consequences, et cetera, and how does this change the trajectory of somebody's life? The children, by and large, and particularly the younger children, are not thinking in that way. So it's a very different assessment of what the event is. The context and background also matter, and we will talk more about that. Okay. The one thing I wanted to to mention about this is that, as Dr. Shemesh mentioned, I actually grew up in the DSM-3 era and then the DSM-4 era, which was a revelation to actually get into DSM-4, DSM-5, so we've removed that extreme immediate response, which is really very useful because it was totally useless in working with children and is useless for most people. What do they remember about what happened at that moment if it's any time in the past? There have been studies, though, that the support of that is that we know that a physiologic response at the time is somewhat of an indicator. And in fact, I had one physiological psychologist who said, oh, I know what we need to do. We need to just give beta blockers to all of the children so that they won't have elevation of their heart rate, and then they won't have a post-traumatic stress response. And I had to sort of explain to her that actually at the site of an accident or in the hospital, we really don't want to interfere with the reactivity of the heart. But I appreciated what she was trying to do. There's still a lot of argument about what that means, and is that representative of a biological underpinning, et cetera. But what it does suggest, and that just I want to put out there, is that pain control is really important. I think we don't have to worry about that quite the way that we used to, where there were active arguments about whether babies even experienced pain. Because they didn't react the same way that adults did, so we didn't have to do any kind of anesthesia for them because they didn't really experience pain. Now, I think we've backed off of putting people under, children under general anesthesia just to do a bone marrow biopsy. But I think that understanding that you are traumatizing a child, or at least creating a potential triggering memory for them by an extremely painful event, can be really important, and that it's and having an elevated heart rate, an elevated stress response is not a good thing, even if you're only thinking about it medically rather than psychiatrically. So that kind of the issue of pain control is quite important. Now I'm going to get much more psychological, though. We're going to be talking about the ecological model. How many of you use an ecological model on a daily basis? Yeah, all of the social workers, I would think. No? Yeah, pardon? Yes. Yes, okay. So one of the things here, one of the things that we try to teach in terms of thinking about a trauma-informed approach is to think of an ecological model. So this is can be visualized. The people I work with at the National Child Traumatic Stress Network really love doing drawings and so on. Me, not so much. So I'm not going to necessarily show you the protective shield, because as far as I'm concerned, it's an elongated oval that you draw on. But what the concept of it is that I think is really important that we'll talk about is thinking about not just the risk factors, but also the protective factors for a child, and thinking about them at many different levels. So, for example, most of us are very well trained to think about all the risk factors. And in fact, in medical training, we seem to only focus on the risk factors. I am assured by my social work colleagues that they are trained to look for the positives, and that their job is to tell us to think about the positives. What we try to do is have it in the model, both of those, and you have to be able to think about them carefully. And the tricky thing about it is that sometimes something is both a risk factor and a protective factor. And I'll see if I can get into that a little bit. But the ecological model is that you're thinking about the child in the context of the family, family in the context of the community, and the community in the context of society. So people who work with children, the ecological model is sort of automatic. With adults, somehow they keep pretending that you can treat an individual all by themselves as though they're not in a context. With children, we can't even pretend that. They come connected with family. But I think we sometimes forget that they also come connected with a community, and it's in the context of a society. And the community can be different things. Some of what you've already heard about is the community, meaning whether you're Hebrew speaking or Arabic speaking, if you are Orthodox or you're secular, those are community issues, and those are extremely powerful. And they impact the family as well as the child. And then the society would be usually at the city or country level. For us in the United States, it's often about what are the protective laws, are there reporting laws, are people going to intervene in the schools? Are they going to know what to do with children coming back into the schools who are immunosuppressed, for example? Those kinds of things are part of the society and community. Okay. So this is just some examples of how you would fill in something, and I'm just filling in the protective factors because usually filling in the risk factors is not such an issue for people. But for the child, we're thinking about both intrinsic and extrinsic things about the child, things that are part of their initial equipment, as well as things that they're sort of bringing with them. So with a child, you know, for example, if we've got a child who has good coping skills to begin with, we've got a lot going for us. That's really good. If we've got a child who already had attention deficit disorder, more problematic. So those are some of the things you'd want to look at in both directions. The family, caring parents are obviously something you would think of as a protective factor. The problem is that sometimes caring parents can also be a risk factor if the caring parents are overly intrusive, are very critical, are throwing fits in the hospital, are being overly protective, those kinds of undermining the coping skills of the child. That caring parent can be both a risk factor and a protective factor. And so part of doing the exercise of listing these is to figure out, okay, what are our targets going to be? And how do we think about this in a more holistic way? Community support from the school, society, it could be, you know, sometimes the community actually is the hospital, but sometimes it's what is society, what has society decided to pay for in terms of what's available within the hospital. At least in my country, this is always a big issue. Not so much here, so that's good. Okay. Let me just make sure I've addressed all of this. Part of what we're looking for with protective factors is what can the child and family depend upon? And we refer to that as the social contract. Now, some parents will tell you that to some extent the social contract, or what they view as the way the world is supposed to work, is that children are not supposed to die before their parents. And so it already feels like this is a violation of the way the world is supposed to work. But another part of that way that the world is supposed to work is that parents shouldn't hurt their children. In the hospital, we think of ourselves doing everything for the child's own good, but it's often hard for the children to understand that. In the very first paper that I wrote, I think you've heard this, when we first submitted a paper on PTSD, I think this was in the early 90s, in medically ill children, one of the pediatrics journals, one of the reviewers said, it's not possible for the children to be traumatized because everything we do is for their own good. I think we've come a long way from that, but it is hard sometimes to remind ourselves what this looks like from the perspective of the child. And I think of that, for example, when we ask parents to hold a child while we're doing a bone marrow aspiration. This feels a lot like a parent helping people torture their child from the child's point of view. And so, you know, now, that can be very comforting to the child. In some cases, if the child actually believes that it's okay, that this is safe because my parent is here, okay, you could perhaps justify it. But it's something to think about. And this is the kind of thinking process that I think is important with this. How do you create any kind of safety for the child? How do you figure out how to make this something that make sense to a child who's at a cognitive level where their logic is magical or their logic is concrete, that they can't think abstractly about this pain is going to help me in the long term. What they are more likely to see is, I was feeling okay and you brought me in here and you did things to me that are making me throw up. So that can be very hard. Okay. We've really already talked about this, that, that the identification of symptoms in the child can be highly variable, that you can have symptoms that are not classically PTSD, but you've already heard about, anxiety, depression, withdrawal, lots of different symptoms can happen because we're really not just talking about PTSD. We're talking about the reaction to a whole series of kinds of events. And we've already talked also about the parents being more obviously symptomatic than the children, and how that actually, comes out in a lot of the research. It's also really interesting to me, very early on, you've gotten all of these ranges of symptoms. When I first started working with pediatric oncology, what it looked like was actually that the children who were in active treatment were less symptomatic than normal controls, whereas the parents were very symptomatic. But the children became symptomatic in adolescence and in young adulthood. Well, what was that about? And we initially thought, well, maybe we've just got the wrong paradigm, we're measuring things wrong, et cetera. And so I moved into working with organ transplants, but they had no trouble endorsing lots of symptoms. And I think part of it is because it's very straightforward. If people are cutting you up, then it's clear there's something really wrong. But it also may be that we take really, really good care of kids with pediatric oncology. We're set up to do that. And the symptoms actually show up much more later on. So it's been hard being able to figure out what can we do, what's actually going to be preventative in a longer sense. What I can say for sure is that really what I've just been talking about is being able to enhance these protective factors can make a big difference in terms of symptoms, at least acutely. I don't have longitudinal follow-up on some of these, about what happens long term. Particularly if we are actually able to control for all of the late effects. And I know that reducing some of the physiologic stressors can help a lot for symptoms during the time in the hospital. Now, I've already mentioned about controlling pain. Some of the other things I think are fairly routine in hospitals now, in children's hospitals, but I'm not sure. Reducing intrusions, being able to have times of day when the children know nobody's going to come in and do anything bad to me. Very hard to do in a hospital, but it can be amazingly helpful for children to be able to have a time that they can feel safe. The other thing about reducing intrusions is helping the children to have fewer strangers coming in, to have more constant kinds of caregivers so that they don't have to be overcoming their fear or blunting their reactions to people by just feeling like, oh, I have to just accept that anybody can come in and do anything to me at any time. You really don't want to have children disconnect. That's not really dissociation, but to disconnect in quite that big a way. One of the other things that you can do is create a safe space. That you can say, we will have no painful kinds of procedures in the child's bed. So when the child is in their bed, they are safe. Now, it depends on how you want to define that about, you know, do you never place an IV in somebody's bed? That may be really hard to do. But saying I'm going to only do bone marrow aspirations in a different room, you can probably do that. Those are different levels of stressors for the child. So what I'm going to do now is really use the rest of my time to talk about trauma-informed care using the 12 core concepts that we came up with in those years of arguments within the National Child Traumatic Stress Network. And I've referred to one of those, which is the social contract, violations of the social contract. But these are a few others, and I'm going to talk about them. There are 12 of them. It would take more of the time than we've got to go through all of them, but I'm going to talk about some of the ones that are most pertinent to what you deal with. And you are, certainly you can go onto the National Child Traumatic Stress Network. I checked this morning. You go to the front page of that website, which is just nctsn.org, and you can click on the core concepts. They will be in English, sorry. I think you can get them in Spanish, but not in Hebrew, sorry. So one of them we've talked a lot about already is the impact on the caregiving system. That if you are trying to understand the experience of a traumatic event on a child, any kind of traumatic event, you have to think about it also in terms of what the impact of that traumatic event was on the caregiving system. So that can be the family, it can be the extended family. It can be if there are other people that are involved with caregiving, those people can be strongly impacted by this. And as some of you know, that can be some of the economic effects as well. You have a child that's in the hospital, they have 4 siblings at home. Who's going to stay with the child in the hospital? Somebody's got to work, somebody's got to take care of the siblings. You know, and this is a marathon and not a sprint. This is not a short-term kind of event. So how do you work that out? This is a big problem. And sometimes the caregiving system will be large enough to be able to accommodate that. The caregiving system often can include a religious community. Where they will be helping with providing meals or providing childcare, or maybe other people will sit with the child. There can be different kinds of people that would be involved at that point in the caregiving system, but it has a huge ripple effect. Safety as a priority is another piece that I've just been talking about. That if you've been traumatized, if once you've had a violation of your safety and you no longer feel like my parents can protect me from anything, which is happily, hopefully what most very small children believe. Once that's been broken, then having that fear about safety, about how do I preserve safety, becomes much more key. And that's why having things like a safe time or a safe space or some safe people that are very important. You know, in the hospital that I work with, I don't wear a white coat, and when I go in, I proclaim, I'm not going to touch you. You know, I'm a non-needle doctor. You know, so I mean, but that's important. Because Nobody else, there were very few other people who walk into the room who are in that situation. I'm not going to poke them. I'm not going to do a dressing change. I'm not going to do anything painful to them. The impact on the development of the child has also been alluded to, although it was the more concrete issues about what we do when we actually cut out parts of a child's brain or we poison the child's brain with chemotherapy or radiation. But also, if you have a child spending long periods of time in the hospital or out of regular school or out of regular interactions with other children, this affects their development. It impacts them. Now, in some ways, and this goes back to, I think we'll be talking later about post-traumatic growth. When we've talked with some of these, the cancer survivors, they will say, I grew from that. I'm different from that. I don't sweat the small stuff now, which we think of as very adult. It also makes you really weird as a teenager. And so they wind up being very different from other people. And so it's not always a good thing. The secondary adversities are the kinds of things that are consequences of what has happened there. For example, if you had to move to be closer to the hospital, or if both of your parents were employed and one of them had to quit their job. There are secondary adversities. You can't take holidays. You can't do other things that you used to do. You may not celebrate some of the holidays in the same way. The one, we've really talked about the impact of culture, so the last one I'm going to talk about is the secondary or vicarious traumatic stress. This is what we always refer to as core concept 12. It's the last and not the least. This is about you. Dealing with traumatized children, dealing with children who are potentially dying, children who've had traumatic brain injuries, children who've had to have parts of their brain removed at a very young age. This has an impact on us. And we have to recognize that and be able to address that. In most cases, this is best addressed within the team. Our loved ones outside don't really like to hear about this. When I talk about some of these things with my husband, for example, he lectures me about how I should have gone into sports medicine. They're all healthy. Nobody dies, which is not actually true. But so yeah. So I talk with my colleagues, and we can understand the nuance, and we can laugh and cry together. But it also is important to know that you have to laugh and cry, and that you also have to take some time off emotionally. Because what I say to my trainees is that if you don't grieve when one of the children you've been working with dies, then you weren't connected enough. But if you do grieve, then you need to give yourself a little bit of time, because grieving is hard. And it takes a lot of energy. And so we're going to try to not have you have somebody else quite that sick for a little while to work with. This is really hard in palliative care. But we try to do that. And what we make a big point of doing in doing all of our training is recognizing, when we come to parts of our training cases, saying, every time I look at this part of the case, I feel it in my gut. What are you feeling? Don't go numb on this. It's okay to feel it. This is the time. We're not going to talk about it. We're not going to have everybody go into a group therapy session, but I want you to be able to use that, to feel it, and be able to let go of it afterwards. So I told you it was my last slide. I'm going to just thank a few people here, because the reason I'm here is because of Dr. Shemesh and Dr. Gaurav. But also what I'm talking about is all really from the National Child Traumatic Stress Network. And I made Dr. Shemesh promise he would not actually take pictures of my slides, because I only have the David Geffen School of Medicine logo and not the Child Traumatic Stress Network logo, and it should definitely have that. But you will consider yourself logoed on this one. Thank you very much.
Thank you, Professor Stuber. We would take 2 short questions.
Okay.
Me? First of all, go Bruins. I wanted to ask, you mentioned language as a factor. Maybe in California you experience this also with immigrants and dreamers, that is when you receive treatment and your caretakers speak your secondary language as opposed to your mother tongue. Does that have an influence on the experience and on the aftermath?
Did everyone hear the question? Okay, because we're talking about language and whether if the medical team is dealing with you in a language that is not your primary language, how does that impact you? It's a huge impact. Part of it is we get a lot of information just sort of through osmosis. I mean, there's a lot of things that are said around us or said on rounds that are not necessarily translated. The other thing is that unless you have a really good interpreter, a lot of things are missed in translation. One of the rules that we have is you cannot use a family member as a translator. It's the most frequently broken rule. Sometimes we'll actually be in the horrible situation where the translator of the family is the patient, the child, because they've been in the country long enough that they are pretty fluently bilingual and the parents are not. And so they're trying to explain everything to each other. The other thing that I've experienced, and I don't know if you get that here, is that I have worked with some interpreters who will not translate some things because they think it's inappropriate to say to a lady, to a child, to a grandparent, and so they just don't do it. And I can, if it's in Spanish, I can figure that out. I speak a lot more Spanish than I do Hebrew. But if it's in Arabic, which is what it was in this one case, I had no idea. The only way I could tell was that they were talking and talking and talking, and I had said one sentence. So I knew they weren't talking about what I had said. I wasn't sure what they were talking about. So a lot can be lost there. But you also just feel so much more alone if no one around you is speaking your language. So I think that increases the trauma.
Are there any more questions? Okay, if not, thank you very much again.
Thank you.